23, we can start now.
Okay, let's start. Hello, everyone. Welcome to our weekly webinar organized by the College of Physicians Malaysia. There's still some background sound.
Okay, so get up.
Okay, so our topic, our theme for the month is respiratory medicine, and our topic for today is very interesting: CHYLOTHORAX, which will be presented by our speaker, Dr. Sangeeta Badivelu, and our chairperson for today is Dr. Kaur In Shi. Dr. Kaur is a respiratory physician who is currently based in Hospital Taiping. So, without further ado, let us welcome Dr. Kaur.
Thank you, Dr. Kelvin, for the introduction. Good afternoon and welcome to this webinar. This is my honor to be the chairperson of this respiratory medicine series and to present to you Dr. Sangeeta Badivelu for her topic of CHYLOTHORAX. A bit about Dr. Sangeeta. Dr. Sangeeta has completed her fellowship in respiratory medicine under MOH Ministry of Health. She is a passionate respiratory physician and has organized multiple courses, lectures, and have delivered talks on respiratory field at various platforms. She is also the examiner of AIMS and Penang Medical College. And with that, I pass the platform to Dr. Sangeeta. Please welcome Dr. Sangeeta with her presentation on CHYLOTHORAX.
Thank you, Dr. Kaur, for the kind introduction. Thank you, College of Physicians, for the invite. It was an honor to be able to speak on this platform today. So I was assigned the task to present on CHYLOTHORAX. So today we'll be discussing on the etiology, diagnosis, and therapeutic options available for CHYLOTHORAX. So before we go into the topic per se, it is quite essential for us to understand the anatomy of the lymphatic system to understand CHYLOTHORAX. So thoracic duct is actually the largest lymphatic trunk which drains chyle and most lymph of the body. It extends from the upper abdomen at the lower border of the T12 to the lower part of the neck, crossing over to the left side to enter the superior mediastinum at the level of the 5th thoracic vertebrae. So then it ascends behind the aortic arch and the left subclavian artery between the left side of the esophagus and the left pleura. It's beaded in appearance due to the presence of many valves in its lumen. So the area of drainage for this thoracic duct is it drains lymph from the whole body except the right side of the head and neck, right upper limb, right lung and thoracic wall, and right side of the heart and right surface of the liver. Everywhere else, 3/4 of the areas of the body is drained. The lymphatic drainage is by the thoracic duct. So let's look at the course of the thoracic duct. Thoracic duct, as has got a long course, it begins in the abdomen at the lower border of T12 as a continuation of cisterna chyli. It enters the posterior mediastinum through the aortic opening of the diaphragm. At C7, it arches laterally and downwards, and it ends at an angle formed by the union of the left IJV and the left subclavian vein. So if you can see here in the cartoon there at the T5 vertebra, the thoracic duct would cross over to the, if you could see my cursor here, it crosses over here and it goes to the left side, inclines to the left and goes up into the superior mediastinum and ends at the left subclavian and left IJV. There's an angle there. So chyle actually is derived from the word chylus, which is a Greek word which means fluid. So, and it's mainly composed of lipids, 60 to 70% of ingested fats absorbed by intestinal lymphatics, proteins, electrolytes, cellular elements, and miscellaneous other elements, mainly fat-soluble vitamins, urea, nitrogen, and enzymes. So what is actually CHYLOTHORAX? CHYLOTHORAX actually is a rare condition, but currently not so rare anymore because I've been receiving quite a number of referrals. It's a condition resulting from lymph formed in the digestive system, which is CAR, accumulating in the pleural cavity due to either disruption or obstruction of the thoracic duct. In a normal adult, thoracic duct transports up to 2.4 liters of CAR per day. So usually it has got this condition has a high prevalence after various cardiothoracic surgeries, mainly esophagostomy, which carries the highest risk of 5 to 10%, followed by lung resection with mediastinal lymph node resection, about 3 to 7% risk. But saying that any other surgeries involving the mediastinal, which causes a breach in the integrity of the thoracic duct, in the mediastinal, would cause a chylothorax. So going into the etiology of chylothorax, let's divide it into two, which is the traumatic and the non-traumatic causes of chylothorax. If you go down the traumatic line of list of causes, you can further subdivide it into non-iatrogenic and iatrogenic. The non-iatrogenic would be any causes ranging from stab wounds, knife wounds, blast injuries, gunshot wounds, childbirth. What happens during childbirth is there is disruption of thoracic duct due to the high intrathoracic pressure generated when during the Valsalva maneuver used during the pushing of the mother during labor. So looking at the iatrogenic causes, it could be again injuries causes to the thoracic duct by thoracic surgeries in the mediastinum, head and neck surgeries, radiation. And going into the non-traumatic causes, we can further divide it into malignancy, idiopathic, and also diseases. Common diseases known to cause chylothorax are sarcoidosis, lymphangiomyomatosis, filariasis, tuberculosis, and a whole other list of etiologies. So again, this is a case series done by Valentine et al. And also Duer et al. Again, looking at the etiology of chylothorax. If you can look here, looking at the traumatic, the non-traumatic part of causes of chylothorax. Again, malignant causes, mainly lymphomatous causes, it predominates at 70%, followed by the highest, again, iatrogenic or traumatic causes, which are mainly surgery, or any injury causing a breach to the thoracic duct in the mediastinum, which is about 48%. So both the case series almost showed similar results. Chylothorax, the effusion may be unilateral. It's either right about 50% of the time, or is left-sided about 33%, or sometimes it could even be bilateral at 16.6%, depending on the site of leak. Damage to the duct above fifth to thoracic vertebrae results in a left-sided effusion. Again, you have to recall back again the anatomy which I mentioned earlier, and then you will know the reason why damage above the fifth thoracic vertebrae will cause a left-sided, because again, as I told you and I showed you this now, at the fifth thoracic vertebrae, it will be inclining more towards the left, hence a left-sided effusion. So what investigations can be sent to confirm this condition, and what are the purpose of these investigations? So initial investigations are usually done to, number one, confirm the diagnosis by fluid analysis, and number two, mainly to identify the site of leakage or the leakage point. So traumatic cases and post-operative cases requires adequate and careful monitoring, especially those with persistent drainage via chest tube. Non-traumatic cases, CT abdomen and thorax has to be performed. So if possible, if your center has a lymph angiography, then a lymph angiography would be ideal to demonstrate the site of leakage or blockage. High fat content injection with methylene blue can demonstrate further also the site of damage during surgery. So again, since chylothorax is just the accumulation of chyle in the pleural cavity, a chest X-ray would mainly show you a right-sided or left-sided effusion or a bilateral effusion. It will not be able to tell you chylothorax on chest X-ray. It will just be able to tell you the presence of a pleural effusion. So definitive investigations would again be thoracosynthesis and laboratory analysis of the pleural fluid. We could centrifuge the pleural fluid, add 1.2 mils of ethyl ether and stain it with student-free. The reason why we stain it with student-free is to demonstrate the chylomicrons, which is a highly sensitive test, but it's not specific, unfortunately. In centers with available facilities, lipoprotein analysis demonstrating chylomicrons is the gold standard test. But however, it's not available in many centers. So again, as I told you earlier, CT, thorax, and abdomen would be helpful to identify the cause of this chylothorax. Looking at the CT scan, I'm sure you could appreciate that there is a presence of, this is the mediastinal window of a CT thorax. You could appreciate here the presence of a para-aortic lymph node. And over this, this slice, it shows a very large, bulky, right-sided hilar lymph node. So this is how a lymph angiogram would look like if we were to do a lymph angiogram. As you can see, those things which are lighted up, that is actually the beaded, and which appears beaded is actually the beaded appearance of your thoracic duct, which is beaded because of the presence of multiple valves. So going into the biochemical diagnosis of chylothorax, so what are we actually looking for when we are sending this chyle or this fluid for biochemistry? So mainly cell counts, it will be predominantly lymphocytes, usually will be greater than 70%, or total nucleated cell count, which contributes towards the bacteriostatic nature of the chyle. So because of the bacteriostatic nature of the chyle rarely gets, the chylous fluid rarely gets infected. So we also look at the electrolytes and protein. Chyle has similar electrolyte and protein content with plasma. 85% of chylothoraces have high protein content, marking them exudates by light criteria. So in chylothorax, LDH levels are low, and elevated LDH levels are usually associated with underlying causes of chylothorax, mainly maybe lymphoma or other forms of malignancy, rather than a simple leakage or an iatrogenic cause of chylothorax. So again, looking at the pleural fluid parameters of triglycerides, a pleural fluid triglyceride level more than 1.24 millimoles or 110 milligrams per deciliter, whichever units you use in your lab, with a cholesterol level of less than 5.18 millimoles per liter or 200 milligrams per deciliter is diagnostic of chylothorax. Okay, this is just exactly what I told you just now, but only that it's in a simpler algorithm manner, more systematic. So if you were to suspect presence of chylothorax by appearance in any of your patients, then again, subject your patients to a diagnostic tab, and you could send that for biochemistry. Look at the cholesterol levels. If your cholesterol levels are again less than 5.8, you should again look at your triglyceride levels. If your triglyceride levels are less than 1.24, chylothorax is unlikely. Think of other causes of a milky kind of effusion. And if your triglycerides level are more than 1.24, then chylothorax is likely. And your next task would be again to identify the cause of the chylothorax and also to locate the site of the leakage. And if on the other hand, if your cholesterol levels are more than 5.18, then it's unlikely to be chylothorax. So it's possibly a cholesterol pleural effusion. So you should look for other causes which could cause cholesterol pleural effusion or pseudo-chylothorax, mainly diseases, granulomatous diseases like tuberculosis. Okay. So again, to highlight the differences between chylothorax and another entity called pseudo-chylothorax. So in chylothorax, triglycerides level are more than 1.24 or 110 milligrams per deciliter, with a cholesterol level less than 200 milligrams per deciliter. Chylomicrons would be absent in chylothorax, and cholesterol crystals are not seen. Versus the other condition, which is a pseudo-chylothorax condition, triglycerides levels are usually less than 50 milligrams per deciliter with a high cholesterol content of 200 milligrams per deciliter. Here, chylomicrons are absent and cholesterol crystals are often seen. as I mentioned earlier, pseudochylothorax usually are seen in tuberculous conditions, pleurisy, chronic pneumothorax, rheumatoid pleurisy, poorly evacuated emphysema, and also chronic hemothorax. Other differentials for chylothorax are, of course, cholesterol effusion, whereby you will have cholesterol levels of more than 200 milligrams per deciliter, or empyema, whereby it would be followed by presence of clinical features which would support infection like fever, chest pain, high leukocyte counts, and supernatant of the pleural fluid usually clears with centrifugation. So when you would take the empyema fluid and centrifuge it, it will usually clear out, the supernatant will be clear. Versus chylothorax, if you were to centrifuge it, the supernatant would remain milky and it will not clear out. So looking at the treatment depends on the cause of the chylothorax. And most patients usually benefit from a staged care plan, from least invasive option to more invasive option. Usually we would try with minimal invasive options first before attempting more invasive options like surgical, which we would leave until it's really indicated. So looking at this algorithm or this cartoon, if there are a presence of unilateral or bilateral pleural effusion in your patient, and you subject your patient to a diagnostic thoracostosis, and whereby there is a clinical suspicion of chylothorax, okay, either by appearance of a white yellowish aspirate, whether there's a high index of suspicion of trauma, whether the patient has got some underlying known malignancy as lymphoma, all these are clues to suspect for chylothorax. Again, you would send this for biochemical analysis. High triglyceride levels, low cholesterol levels with the presence of chylomicrons would again suggest chylothorax, and it would be exudative by like criteria. So you would investigate further and treat the etiology of this chylothorax. So treatment, as I said earlier, we would start with a least invasive approach. So conservative treatment would comprise of keeping the patient kneel by mouth and starting the patient on a low-fat diet. What I mean by a low-fat diet is a fat diet of less than 5 kilocalories of fat per meal. And also you could start the patient on oral medium chain triglycerides or MCT oils. Put the patient on total parenteral nutrition. You could also, if the patient is symptomatic of the chylothorax, meaning there are a lot of chyle in his pleural cavity, because as I told you earlier, the thoracic duct is able to produce about 2.4 liters of chyle per day. So, and so the patient could have a very massive pleural effusion and be symptomatic. Hence, some patients you would need to put an indwelling chest drain to relieve the breathlessness, and also plan for a third pleurodesis later. So when do we decide for surgery is when the fluid is, or your chest tube is persistently draining more than 1.5 liters per day per day, or more than 1 liter per day for 5 consecutive days. Or if the patient is having persistent leak for 2 weeks, or you are having, or the patient is already showing some signs or metabolic compromise or nutritional compromise. Because as I told you that this chylous fluid is very, very high in proteins and is also very high in immunoglobulins. So if the patient is persistently leaking or persistently draining chyle, in the long run or in the short run, the patient will be very malnourished, and he is very prone to infections because he's losing a lot of immunoglobulins. So, and then we could refer this patient again to our thoracic surgeons for a surgical treatment, or and the surgical treatments which are available now is again ligation of the leak under direct supervision. You can either use a WEDS approach or an open surgery method, or a mass ligation of the thoracic duct, surgical pleurodesis, pleurectomy, or pleuroperitoneal shunt or pleurovenous shunt. So again, this is what I've already mentioned. Other imaging therapies which are available now is somatostatin, octreotide, mitotrine, sirolimus, which are known or have been proven to reduce the chyle production from the thoracic duct. And also there are also some centers which are doing thoracic duct embolization. But saying that, there is a high failure rate for thoracic duct embolization since as we already saw just now, the course of the thoracic duct is very long, and it's a very extensive network of plexus, causing a very high failure rate of the thoracic the embolization of the thoracic duct, which could only be done by an interventional radiologist. So failure of conservative treatment, again, as I mentioned, requires surgery. In an experienced surgeon, the rate of the success of surgery is usually as high as 90 to 100% in a very high volume and a very experienced surgeon. So this I've already mentioned. These are the available surgical techniques. Those patients who are unfit for surgery due to, they are very malnourished or they have very advanced malignancy causing them to not be fit for surgery, then you could always consider options like pleuroperitoneal and pleurovenous shunting, which has been proven to be useful. But however, these also have its complications like infections, like adhesions, and the clogging of the implants. So I think that's my last slide. Thank you very much for your attention. I'm ready to take any questions if there are any questions.
Yeah, is there any questions? I would welcome you to actually note it in the Q&A box, chat box. If not, I will start the ball first. Okay, Dr. Sanjita, you just mentioned that there can be either a more aggressive approach and more conservative approach to treat the chylothorax. I just wonder, from out of all these conservative approach, which one would you prefer first? Before you actually getting on, you already listed out so many things or so many methods to actually for the conservative management. Which one would you prefer to do, and which one is most important in your opinion?
Thank you for the question. Again, what we normally practice is, and which is very easily done with not much expertise needed, is to subject the patient upon diagnosis on a low-fat or a fat-free diet. Because as we know, a high-fat meal would cause exaggerated production of chyle, which would again, leak into your pleural cavity, causing chylothorax, which will be persistently draining. And so we would again subject our patients first to a fat-free diet or a low-fat diet, and supplement him with medium chain triglycerides. Keep the patient kneel by mouth, and while keeping the patient kneel by mouth, we have to also think about his nutrition, because they are very prone to develop malnutrition. So that's where we can initiate the patient on TPNs or total parenteral nutrition. And when the production of the chyle is less and the drainage is less, hopefully, or we hope that there will be a spontaneous closure or sealing of the leak over the part of the part of the course of the thoracic duct which is injured or breached. So that's what we hope to do by this method. And as I said, if this fails, and it fails to, the leak fails to heal or to self-seal, and the drainage is still significantly high, then we need to definitely consider a surgical treatment, which is the next option which I would recommend in these patients.
Yes, Dr. Sanjita, I have one question from the floor, which is, when do we consider duct fluorosis in chylothorax patients? Do we perform fluorosis right away?
Again, the concept of pleural disease is similar to that of a pleural effusion, whereby if the pleural disease is basically to we would wait for the visceral and the parietal pleura to be approximating each other, or practically hugging each other, so that and that's when you would choose to instill our fluorescent or our sclerosant, which is either talc or any other sclerosing agents. So, and if the effusion is still very high, or it's still highly draining, more than 1 liter per day, obviously the parietal and the visceral pleura will not be approximating each other, hence causing a very high failure rate of your pleural disease. So again, I would recommend this, the suitable time to be would be once the drainage is reducing, probably maybe less than 100 or 200 cc per day, and when the drainage from the chest tube is reducing, and the lungs have expanded, so we would try to do a talc fluorodesis then, or fluorodesis using any other agents, which would result in a higher success rate rather than doing it when immediately upon diagnosis of chylothorax.
Yeah, thank you, Dr. Sanjita, for the answer. Is there any other questions? Or else, I would like to ask another question. Yeah, Dr. Sanjita, how about those with lymphoma? Would you recommend the treatment also institute to treat the underlying causes? And how would you say, you also follow the way that you presented, meaning that you wait for this, see whether the drainage is persistent for 2 weeks, or you can actually give more time for those with malignant lesions, for example, lymphoma, for the chemotherapy to kick in.
Yep. That's why I said this is just algorithmic approach to treatment in a nutshell. Again, the treatment of this condition will depend on the cause. That's why it's very important, and it's really mandatory for us to try to identify the etiology of this chylous effusion, and then the treatment would again we would be guided to the treatment pathway. So if it's because of malignancy, as you rightly pointed out, Dr. Kaur, then I would think I would also want to refer this patient to my hematology colleagues for a biopsy, and also, to initiate treatment for the lymphoma per se as soon as possible without any delay.
Yeah, there's another question, which is, would he or she would like to know which type of patient will benefit for this somatostatin treatment.
So again, these are treatments which are emerging, as I told you, in patients which have high output chylous effusion, who are constantly draining despite your initial conservative therapies, and then and if you would want to buy some time before referring the patient to our friendly thoracic surgeon. So or if also these patients are also not fit for surgery, then we could try medical therapy like giving all the somatostatins, mitodrins, and also sirolimus, which has been studied to reduce the production of chyle. So when the chyle production is less, hopefully the drainage also less, and it would self-heal, or the leakage will be and the breach of the thoracic duct would be self-healed.
Yeah, we have still have some time. Anybody have any burning questions? Another question for you, Dr. Sanjita. What is the success rate of medical care for chylothorax?
The success rate actually in most literatures, it's quite high kind of thing, maybe about 50%. But obviously that is medical treatment. But in surgical, if the patient is willing to undergo surgery and the patient is fit for surgery, of course the success rate in surgery is better. It's as high as 100% in the hands of an experienced surgeon.
Is there any questions, or else I would like to end the session. I think there is no more questions, Dr. Sanjita. Is there any questions? I think you can actually ask us personally or in private next time. I would like to thank the audience for participating in this webinar, and also thank Dr. Sanjita for her time to contribute to this webinar. So the webinar will be adjourned. Thank you.
Thank you very much, Dr. Koh.
Yeah.